Thank you. My old professor said, if you get applause before you start your talk, you're in trouble because everything goes downhill from there. Yeah. So I'm going to cover updates of all these meetings for this year, and I want to thank my friend Dr. Adjei for inviting me, but I have 70 slides to present in 25 minutes. So at the end, you feel like doing this to me. Okay. No conflicts. So in 2025, we have 11 oncogenic drivers that can be targeted in lung cancer, as you see here. And there's a timeline. So you see that unlike GU, you heard about GU, we started 2011, and we've been going since then. And we have a number of PD-1 inhibitors that you see on top approved in the US and EU, and the bottom in blue are the ones that are approved in China. So a lot happening there. And so let's start. We are going to deal with early stage, and then we'll get to metastatic disease. So early stage, I'm just reviewing updated results. So this is Checkmate 816. This was the first neoadjuvant study that was reported a while back, and we've had updates after 5 years at ASCO. And as you can see, the overall survival, 65% versus 55%. So this is a 5-year update. And then there was the perioperative study. This was pure neoadjuvant. So patients just got their chemo, IO, surgery, and then you could do adjuvant or you don't have to do it. But this one was perioperative, so pembrolizumab plus chemo, surgery, and then pembro for 1 year, and also 5-year survival. So as you can see, they are quite identical. Right? I mean, cross-study comparison by identical. So in 2025, these are the studies, and that was being reported out. So we've had the pure adjuvant studies with atezolizumab and pembrolizumab, and then the pure neoadjuvant with nivolumab, and then the perioperative ones, and approved are nivolumab, atezolizumab, pembro, durvalumab. But the unanswered question, we still don't have the answer to that. It's the neoadjuvant study or neoadjuvant treatment alone. Is it just as effective as the perioperative approach? We don't have the answer to that. And one argument that's come up is, if you do neoadjuvant treatment, maybe the patient will not be able to have surgery, right? And actually, in all the studies, the attrition rate was anywhere from 16 to 22% of patients who couldn't get surgery. And some of the reasons are here. And the important thing is that even with chemo and immunotherapy, 4 to 6% of the patients had disease progression, so couldn't get surgery. And so sometimes people use this argument as why you should go straight to surgery and not do neoadjuvant. But I have a case report that causes us to be cautious. So this was a patient, young, 42-year-old with lung cancer, PD-1 expression was high, got 3 cycles of cisgem pembro, and then had horrendous pneumonitis, immune-related, as well as pulmonary embolism, so steroids and anticoagulation. This is his scan here. And then actually, after 3 months, reevaluated, and even on PET, there was residual adenopathy, but 42-year-old healthy, so our surgeons took him to surgery, and it was all granuloma. It wasn't disease, right? So the question is, some of these patients where you do your PET or whatever after neoadjuvant therapy, and you say, well, we are not going to surgery because there's disease progression, we have to be careful. it may not be disease. So this is just a word of caution. So we finished with neoadjuvant immunotherapy. Now let's get to targeted agents. So the only agent that's been used, that's been reported out at ASCO, is osimertinib, the NeoAdora study, 3 arms, single agent osimertinib, osimertinib plus chemo, and then chemo. And the endpoint, primary endpoint, was major pathologic response. The blue is osimertinib and chemo. Red is single agent OC, and then chemo there. So really, in terms of major pathologic response, about 30%, essentially both arms. But the disappointing thing is that the pathologic CR rate was 4% with the combination, 9% with OC, and of course with chemo there were no path CRs. And so you compare this to immunotherapy where the path CR rate is anywhere, depending on the study you look at, 18% to 25%. So this was somewhat disappointing, but certainly it's active. We don't have survival data yet. So let's now move to stage 3. And if you work with radiation oncologists, we've always talked about abscopal effect and also the fact that, when you combine radiation, say SBRT, because you are not radiating a big chunk of the chest. If you do that and you add immunotherapy, you actually get, or you are supposed to get more impressive results. So there was this study in Adjei and SWOG, and it was patients with operable disease surgically, but medically inoperable. And the standard of care is SBRT. And this was compared to induction immunotherapy, followed by SBRT, and then additional immunotherapy. But this study was rock solid negative. And more importantly, the immuno and SBRT arm was more toxic. So you see here 12% grade 3 toxicity compared to 2% for SBRT. And then another radiation study at World Lung. So this was the Pacific regimen, which is chemo, radiation, followed by durvalumab. But the experimental arm was chemo, radiation, and durvalumab. And then you follow with maintenance durvalumab. And this study also was negative. And so it begs the question, when we are combining chemotherapy with immunotherapy, we have to be very careful, because going in, the feeling was that this was going to be a positive study. So that's for the early stage disease. Now let's look at metastatic disease. Let's start from the Mariposa study. This was that ELCC, European Lung Cancer Meeting. So this is the combination of amivantamab and lazertinib. Lazertinib is a third generation TKI like osimertinib, and this was compared to osimertinib and then single agent lazertinib. There had been the response rate favored the combo arm, and PFS also. At ELCC, we had the survival data. So you see here the hazard ratio is 0.75, so survival benefit. But the issue is that that combination is toxic. And so you see toxicities here. I think the concerning thing is that even after a year, you still have some people who develop DVTs and so on. So a lot of the toxicities are the first 4 months, but even up to a year, you are seeing toxicity, and there's elaborate prevention done to mitigate these toxicities. So steroids before, the day before, day of treatment, actually it's 2 days before, and then prophylaxis against clotting, antibiotic prophylaxis with minocycline, and actually using chlorhexidine on the fingernails and toenails and so on. So very complex regimen of prevention. But when you do that, as you can see, the incidence of toxicity goes down significantly. But remember that still you have a fair amount of toxicity, right? If you look at clotting is still 11%, right? And so prophylaxis helps, but you still have a fair amount of toxicity. Okay, and then on the same theme, the FLORA-2 study where you are adding osimertinib to pemetrexed carboplatin compared to osimertinib was first reported about 2 years ago. There was a PFS benefit, but at the World Lung updated results show that there was also a survival benefit. So you see here, median survival 47.5 versus 37.6 months. So begs the question now, you have a patient, you see EGFR mutated, what do? Do you use osimertinib alone? Do you use carboplatin, pemetrexed, osimertinib, or amivantamab, lazertinib? So it's a big question. The only thing I'll say here, and we can discuss it later, is that remember, our patients are living longer, and toxicity can be an issue. And you see here with this combination, if you look at grade 3 or higher toxicity, 70% with the combination compared to osimertinib alone, 34%. And a good colleague of mine, Jill Feldman, who's a patient advocate, who talks about her story. And this is Jill, and she always talks about chronic toxicities. And if you see her, she's exactly like this, full head of hair, not like me, and looks great. And he says that's what her providers see, but this is how she feels, right? So we'll leave it there. When you are thinking about which regimen to use, talk to your patients, think about the toxicity. It's significant. Okay, moving on. And so we know that immunotherapy doesn't help everybody, and even when it works, sometimes the disease progresses. And we've looked at multiple reasons for resistance. And as you can see here, tumor factors, host factors, tumor microenvironment. And so the idea is that the checkpoint inhibitors, the checkpoints are a lot. And we happen to pick on PD-1, PD-L1 first, and they seem to be the biggest driver, so we've been successful. But there are all these other inhibitory checkpoints on the tumor, as you can see here, and on the T cell. And so there have been attempts to combine some of these things to see if we can do better. And TIGIT has been a very important one because it's on the immune cells. And there was this study, tiragolumab, which has shown actually impressive phase 2 data. So there was the Skyscraper 01 presented at ASCO, where it's tira plus atezo versus atezo alone, and it was actually a negative study. And as you can see here, there are multiple companies with these TIGIT. Like I said, it was a very hot target. And if you follow my cursor, you see that they've all been negative. All right? So TIGIT hasn't worked out. Okay. Okay. And the idea then was that you had anti-TIGIT, you have anti-PD-1, we combined them, didn't work. So what about bispecifics, right? Where you have one antibody and one binds one receptor, one binds the other, one brings them together. So the feeling was that this is where we might make some progress. And you can see here multiple combinations of PD-1 or PD-L1 with all these factors that are felt to be important in the immune microenvironment. And I think in spite of all of these, TIGIT, LAG3, and so on, VEGF has turned out to be one that we keep going back to. So there are about 10 different bispecific targeting VEGF. And this one was the one that caused a lot of stir a couple of ASCOs ago. This is ivonescimab, developed in China. It's a PD-L1, as you can see here, anti-VEGF at the top, and PD-1 at the bottom. So it binds PD-1 and it binds VEGF-A. And there was the initial study that showed that head-to-head against pembrolizumab, there was a significant PFS benefit, all right? And so at World Lung, this study was presented. So these patients with EGFR mutation whose disease has progressed, ivonescimab plus chemotherapy versus placebo plus chemotherapy. And as you can see here, PFS, there was a difference, but overall survival, there was actually no benefit. And then at ESMO, a second study was presented. This is frontline, ivonescimab plus chemotherapy versus tislelizumab, which is a PD-1 inhibitor developed in China, plus chemotherapy head-to-head. And here, significant improvement, as you can see here in PFS, 11.1 months versus 6.9. And so this was a positive study. This is the endpoint. But based on the previous study I just showed you, we are cautious. We are waiting for survival results. But the interesting thing is that the PFS in different populations of PD-1 expressors were different PD-L1 expressors, right? So it's sort of inversely proportional, hazard ratio inversely proportional to PD-L1 expression. So you have the most benefit in less than 1%, and actually the greater than 50%, not as impressive. So interesting, we'll keep an eye on that. So now let's get to targeted therapy. So this is HER2. A lot of drugs have been tested in this era. And, you know, we've had some successes, but an ADC was the one that, TDXD was the one that was approved for these mutations. Most of them are in the tyrosine kinase domain, as you can see here. And then there are a few in the non-tyrosine kinase domain. So there, the thing is that most of the, apart from the ADCs, most of the TKIs have not been as effective in the non-tyrosine kinase domain mutations. And this was presented at AACR. This just shows the efforts at targeting HER2 mutations. And as you can see, we've had variable success. Toxicity has been a big issue. So this drug, zongertinib, is a TKI, very sensitive, and it doesn't affect normal wild-type EGFR. So that was a benefit. And this was a study design where there were multiple cohorts. Cohort 1 with, these are all cohort 1, 5, and 3 are previously treated, and cohort 2 was frontline. So at AACR, this was presented. Patients with TKD mutations, look at the response rate, 71%, and look at the waterfall plot here, very impressive. And more importantly, you know, the ADC, DXD, the problem is ILD, interstitial lung disease, which can be very challenging and can actually be fatal. And this is a tyrosine kinase inhibitor without any ILD reported in these studies. And in patients with cohort 5, so previously treated with an ADC, you still have a response rate of about 48%. And then this is the non-TKD mutations, difficult to target, but you still have a response rate of 30%. And just at ESMO, the frontline study was presented, and I missed that. We missed, somehow it didn't show, but there was a frontline study presented, and that was also very active with these waterfall plots. And actually, I have my famous water plot decoder for, but I don't see any students here. I use it to teach the students about how to interpret a waterfall plot, right? So when it's down, it's great. When it's up there, it means that stuff sucks. Right? That's all you need to know. That's all you need to remember from this lecture, how to interpret this, right? Okay, now let's get to antibody-drug conjugates. So as you know, the whole idea is that you have an antibody and you have a linker and you have a very toxic chemo drug, and the antibody binds an antigen on the tumor surface and you get the drug into the cell. So as it were, targeted chemotherapy, and the toxophores are usually very potent chemo drugs that you couldn't give IV. So for instance, the anti-tubulin ones, maytansine and so on, are about 50-fold more potent than paclitaxel. And so that's been the idea. And we have multiple of them being tested in non-small cell lung cancer. And we actually have 3 of them approved, as you can see here. The second and third one are approved in China, not in the US. And then TDXD we talked about, and Dato-DXD, and telizolizumab, the latest to be approved for MET expression, right? And there was this one, HER3-DXD. We're very excited about it because, as you know, there are 4 members of the EGFR family, HER1, 2, 3, 4. And HER3 is supposed to be important in resistance, right? And it actually doesn't have a kinase domain, it doesn't signal. But so the idea is that a HER3 antibody will be very useful in EGFR mutant tumors that are resistant. So they've progressed on osimertinib or erlotinib or a TKI, and the feeling is that HER3 plays a part in that. And so this study, unfortunately, was negative. So with the ADCs, there's a lot of excitement, but when it comes to lung cancer, it's not clear whether they will be really the game changers we thought they would be. As you can see here, you know, we have a number of negative studies. So TROP2, we really were excited about it, but the studies in all comers was negative. And the positive study was only in the EGFR mutant patients, right? And then we have TDXD I talked about for HER2 expression. And the thing is that with TROP2 being effective in the EGFR mutant population, there's another TROP2 ADC approved in China. It's not clear whether TROP2 could be doing something in the EGFR mutant population, but the ADC is still an issue. And then there was this study presented at ASCO. This was an exciting study, you know, Pragmatica. So this is a pragmatic trial. And we haven't done this in oncology a lot, but they do it in ophthalmology and other diseases, which is that instead of doing our traditional study where you have strict eligibility criteria, you dictate when everybody does a CT scan, and so on and so forth. The pragmatic trial, you randomize the patients, and the oncologist treats the patient like they would do in normal life. You know, so very few eligibility criteria. You do your imaging whenever you like, and we collect the data at the end. So it's a more powerful way of getting data other than real world. You know, the real world is still retrospective. You go to databases and you look at what people do. But here, you are taking people who have been treated the normal way and you collect the data. So it was very exciting. It accrued. So if you see here, for the US, for phase 3 cooperative group study to accrue in a year and a half is unheard of. And that's because of the pragmatic design. But unfortunately, it was negative. And the take-home point from Konstantin Dragnev, was that, well, it didn't improve OS, but it was no worse than chemo, so it might be an option. Well, that would be well and good if it was upfront, but this is a second-line study, right? So the idea of a chemo-free option with pembro and ramucirumab really will not fly because the patients would have had a checkpoint inhibitor already. So unfortunately, this was negative. So quickly with small cell. So all of this was non-small cell. So small cell, there are two studies that I wanted to discuss. So at ASCO, this IMforte trial was presented. So this is atezo, carbo, etoposide, and then after 4 cycles, you randomize to maintenance, lurbinectedin plus atezo versus atezo. And this was a positive study, as you can see, with the PFS and overall survival. And it's now approved by the FDA. So you can do maintenance atezo plus lurbinectedin. But again, harking back to the earlier point, you have to be aware of toxicities. So if you look at grade 3, 4 toxicities, 25.6% with the lurbinectedin plus atezolizumab arm compared to atezolizumab alone. And then the next one is tarlatamab. So if you are aware, second line, tarlatamab was given accelerated approval based on a single arm study. And so this was the randomized trial of tarlatamab compared to chemo. And in this study, it was dealer's choice, but the chemo was really topotecan and lurbinectedin. And then in Japan, it was amilrubicin. So one of the 3 chemo drugs. And this was actually positive. And so we expect that the FDA will give full approval to tarlatamab based on this randomized phase 3 study. So if you look at the toxicity with tala, in terms of our traditional toxicities, you look at it compared to chemo, not that toxic, right? But the problem is the cytokine release syndrome, where the patient can have fever, rigors, hypotension, tachycardia, hypoxia, and so on. And then the scary immune effector cell-associated neurotoxicity syndrome, that's the ICANS. That's where they get tremors, confusion, they can actually have seizures. So as you all know, when we give tarlatamab, we have to keep the patient under observation for 1 day before we let them go. I wish we had biomarkers to predict for this because most patients are fine, but a few patients can get into trouble. The only tidbit I can give you is that the CRS tends to correspond to volume of disease. The patients with a large disease burden almost always get bad CRS. So if you have a patient with a large disease burden, you should be aware of that. Actually, in my practice, if I get somebody with bulky disease, I try to debulk first before I bring in the tarlatamab but if not, then I admit them and you have to watch them very carefully. So that's all I have, folks, but to make sure that you took all in, I have a quiz for you. And if you can't answer these, we are not leaving. It means you haven't learned anything. Any takers? No? Okay. What about? I went back. Okay. What about this one? Okay. Now the next one, everybody can answer, and then we're done. Any takers? Thank you very much.
Yeah, I think this is kind of a generic comment, but I think you've touched on it quite a bit, but it's from a just a pure physician position, you know, rather than a clinical trial side, is I always tell patients everything a physician does to you is another illness. And so when we, as physicians, and I kind of emphasize this, you know, we can be oncologists, but we're physicians first. And I think I try to remind people that our job is physician first, and then the consulting cancer is second. And so the assessment of what we, like your one slide is, what we envision is a, quote, great result may not be so great on what the global impact on a person is. So when you're making a decision on treatment, it isn't entirely a guideline issue. It isn't entirely the slide that shows a 9% disease-free survival difference. The hardest problem is when you're faced with a patient with other multiple comorbid medical issues, which a lot of people have, trying to determine what is the right thing for that person as a physician, not just looking at the data entirely, because the data is important to determine the truth, but that's only a small portion of what we as physicians who take care of cancer patients are responsible for. And I emphasize that because sometimes people get lost in the concept of, here's a cancer, it's progressed, here's the guideline, I give this, but that may not be the right thing for that particular patient. So I just kind of bring us back to the basics, that we're a physician, and that's the hardest part of this. Just treating on a study or a guideline is easy, but determining with that patient in their situation, their family, what is the best for them and what's the value. So that's my 2 cents.
Yeah, it's a good point, and that's why I try to point out it's, as you heard in the GU talk, there's attempts to de-escalate therapy, right? Because we realize that toxicity is a big issue. And the thing is that our patients are living longer, and at this time in 2025, with the agents we have, we are not curing anybody, right? So we have to be aware of the toxicity and think hard before we throw the kitchen sink up front at the patient. That's my view. Mohammed.
Yeah, my question is sort of related to what Dr. Lemming said, but more specifically, you showed NeoAdora, where it was clear that chemotherapy has surprisingly little to add to the efficacy of osimertinib in patients with activating mutations. And you didn't get to show, because of the time, Alina trial, where there was no chemotherapy. It was just in ALK-mutated patients, just targeted therapy versus chemotherapy. It was a resoundingly positive trial. So in a patient in clinic, even though we say from the podium, don't do cross-trial comparisons, don't do extrapolations, but in the clinic, when you have a patient who's a borderline candidate for chemotherapy and has an activating EGFR mutation who's early stage, are you comfortable extrapolating and foregoing chemotherapy in that patient and just doing osimertinib in the adjuvant setting?
Well, yeah, actually there are data, not time to present it. Yulong Wu, again, it's a subset analysis, right? But in this situation, you use that to guide you.
Yeah.
So he did because the way they did the study, and as you probably know, particularly parts of Asia, China, and so on, Japan, the patients will refuse the chemotherapy, right? So in the ADORA study, where it was adjuvant chemo you follow with osimertinib. Some of the patients didn't get any chemo, straight osimertinib. And when they did the subset analysis, the outcome was the same, right? So actually, I'm very comfortable doing osimertinib single agent adjuvant therapy in the patient with an EGFR mutation. I think the biggest question actually didn't have to address it is the duration. Is that 3 years enough? Or like tamoxifen, should we go 5 years? But those studies are being done.
Yes. Thank you.
Wonderful talk. I have a question about tarlatamab in
Yeah.
clinical practice and dosing and scheduling. So one of the things that we're finding is that with these CD3 T-cell engagers, spacing out dosing seems to be better. You get less T-cell exhaustion, maybe better efficacy, and maybe less toxicity. The myeloma world, that seems to be what's going on with the BCMA by CD3s. Have you seen the same thing with tarlatamab in small cell lung cancer? Are you changing from a Q2-week dosing at all?
We haven't done that. So those are studies we are discussing because I agree with you. The thing is that, first of all, you are doing it frequently earlier on. You are dividing the dose to make sure you don't get
The CRS
and so on. And then when you continue, if you look at, like you said, other areas like him where they've done bispecifics a lot, they don't dose that frequently. So those are the studies we are thinking about. Some people feel we don't really have to do that because a lot of the toxicities are earlier on.
Yeah.
So if they don't have CRS and so on, that first week, they are probably fine. But you occasionally get some tox late. So it's a question we need to ask. Also, for the patient, if they can come every 3 weeks, obviously much better.
Agreed. Yeah, we definitely, so we did the tarlatamab studies in prostate cancer, and I remember seeing some odd neurotoxicities that happened later that weren't typical ICANS. So yeah, definitely agree. Thank you.
You're welcome.
Dr. Adjei, I have a question.
Sure.
So, I know we were trying to balance out the side effects and efficacy. I find that sometimes it's hard to pass on something which has a survival advantage, but it does have more toxicity. But, if you add more things, it may work better, but at the cost of side effects. So I don't know how you balance that, because if there's a survival advantage, someone may be willing to go ahead and get that treatment.
Well, the thing is that, these are clinical trials. The results are being read out now, but they were done a while ago, right? So one thing to remember, I gloss over it kind of quickly, but the EGFR mutant patient, osimertinib, disease progresses, you sequence again, you might find a mutation you can treat, right? The most common cause is C797S mutations, and we have a couple of drugs. We have one at our site now that we are testing that look very good, for that. And then remember, Dato-DXd is approved in that setting also. And lazertinib plus chemo is also approved, right? So it's not like there's progression and you're done, there's nothing else for you to do. We have other things to do. So I'll tell you that in my practice, if I'm concerned about the patient, huge disease burden, they are young, no comorbidities, and so on and so forth, yeah, I'll do the combination. But folks I consider normal risk, not a lot of disease burden and so on, or the older, frail patients and so on, I do single agent, right? I mean, I think what could help us would be biomarkers, right? If we could have a way of predicting those, because you and I know that not everybody does well with osimertinib, right? And if we could predict those folks, then we could do the combination in them. And then the folks who are really normal risk, we give OC alone. The other thing to consider is that if you pick the pemetrexed carbo combination, you know, they continue with maintenance, pemetrexed and osimertinib. And if you go into the study, you find that the duration wasn't that long. A lot of people had to stop. So another middle way would be give the combination, maybe a few doses, and then stop the pemetrexed and maintain them on the osimertinib.
So one, I guess, an overarching theme with lung cancer. So stage 4, especially in the area of immunotherapy, we're probably curing a fair subset of patients. Do you think we're going to get there with targeted therapies and say we cured some of these patients?
You're talking about curing patients?
With stage 4 disease.
Targeted therapy, well, even with immunotherapy, you know, it's questionable if we cure anybody, right? In my view, if you look at the mechanism of action, even though we don't use it a lot, something that contains ipilimumab is probably where you might get a cure. And the reason I say that is I remember the PD-1, PD-L1 is blocking at the tumor level. The CTLA-4 inhibitors are blocking CTLA-4 in the lymph nodes. That's where the T cells reside, right? So that's where the tumor is preventing your dendritic cells and so on with the tumor antigen from activating your immune system. And the lymph nodes are where you have some of the memory T cells. So in theory, if you arm those, because you block CTLA-4, you might have memory T cells that will hang around so that if there's micrometastatic disease, it might take care of them. And so if you look at melanoma, there are patients who are now like 15 years out of EP-Nivo who are doing well, right? So we may be able to, with immunotherapy, cure a subset. With targeted therapy, I don't think so. Yeah, I mean, if you just look at the mechanism, you know, if you want to select for resistance in the lab, go grow some cells and just keep treating them with a chemical, right? And then you get a subset that survives and continues, right? And given targeted therapy, that's just killing those mutant cells and so on, that become resistant and now grow. I don't think we are going to cure. And what we are doing now is, it's not chasing our tail, but it's like we treat continuously and then resistance emerges and we have a resistance mutation and we treat that with another drug and then you get a tertiary resistance and you treat and so on. So, you know, we may be able to convert it to a chronic disease where we might have subsequent therapies. You know, chemotherapy is never going to go away. You know, people think it will go away. It will always be there. So I think it's not cure, but more converting the disease to a chronic disease where the patient will live a normal lifespan or something like that. I have one patient I treated with a drug that's dead. It's a farnesyltransferase inhibitor. It was supposed to inhibit RAS, you know, because it inhibits processing of RAS, and it actually failed. But I have one patient started a phase 1 study in July 2000, and she's still alive on the farnesyltransferase inhibitor with stage 4 non-small cell lung cancer. So I don't think she's cured. I mean, I'm not stopping it. I told her, well, maybe you are cured, but we aren't stopping it. And thankfully, we have drug supply and so on. So, it's N of 1 of somebody who, when I treated her, she was, I think, 50. And she's now like 75 years old with stage 4 non-small cell lung cancer. So, but she's not cured. It's chronic disease.
Hi. My question is, with all of these new regimens, how long do you trial them for before you go, you need a lobectomy, or this patient is more qualified for a lobectomy rather than continuing chemotherapy?
You're talking about the neoadjuvant.
Yeah.
Well, normally, we go by the way the studies were done. So the nivolumab studies, they did 3 cycles, and then they went to surgery. With all the others, they do 4 cycles, right? And so the thing is that you finish, if you finish your 4 cycles and you went to surgery and the surgeon said, there's N2 disease, so I can't resect, then I guess you continue treatment. Otherwise, it's 3 to 4. Personally, in my practice, I do 3 cycles because I don't think you really need the 4 cycles. And yeah.
Okay. Thank you.
You're welcome.
Well, thank you very much.
I think I'm safe. There was applause before,
Yes.
and there's applause at the end.
Yes.
Thank you.
Thank you all.